Bismillahirrahmanirrahim. Assalamu alaikum. Now it may be come in the clinical station. So we can found that the child is obese with some sign of hirsutism, increased weight, and whenever after doing the general examination, when our if our task is do the per abdomen examination, after doing general examination we can found that this type of scar, inverted J-shaped scar, and there is some previous scar mark is present, and then on the palpation there may be transplanted kidney there. So what's the case? It's a case of renal transplantation. I think third time renal transplantation with transplanted kidney on the left iliac fossa. So what may be the cause of CKD in children? So there is congenital cause, Alport syndrome, cystinosis, dysplastic kidney, autosomal recessive renal kidney disease, autosomal dominant kidney disease, congenital nephrotic syndrome. It may be IgA nephropathy. Acquired cause may be nephrotic syndrome, glomerulonephritis, ACLE, renal tubular acidosis, and posterior valve obstruction, PUG obstruction. So, what are the indication of renal transplantation? Indication of renal transplantation is that if there is the sign of uremia and such as the lethargy, anorexia, vomiting, acidosis, um, and these symptoms of uremia is not responsive to standard therapy, hypervolemia, hyperkalemia, and there's failure to thrive due to limitation of total calorie intake, metabolic bone disease due to renal osteodystrophy. What is the contraindication? The contraindication is that if there is acute cardiopulmonary, advanced cardiopulmonary disease and active malignancy and severe systemic infection, abuse, major cytic illness, and HIV infection, chronic hepatitis B infection, severe multiple organ damage. So after renal transplantation, what may be the complication? Infection, rejection, dehydration, bleeding, hypertension, obstruction. So and so how will you follow up these children in long term? After the renal transplantation, we will follow up in transplant kidney center and avoid the life attenuated vaccine, avoid to exposure to varicella exposure, avoid the nephrotoxic drug, and prophylactic antibiotic for pneumocystic KNE, cotrimoxazole, and also and valganciclovir for cytomegalovirus, and we will keep the child in our follow-up in the transplant clinic by weight, blood pressure, height, and follow JVP measurement and follow-up of creatinine versus baseline creatinine ratio. And causes of fever in children with renal transplant, it may be due to rejection, infection, UTI, obstructed uropathy, and there may be another case in the station that the child is looking lean and thin, and AV fistula is present, so we have to auscultate to find the buoy, and the child is pale, bowing neck may be present, and there may be multiple drainage for peritoneal dialysis or hemodialysis may be present. So in this scenario, this is a case of chronic renal disease. In case of chronic renal disease, cause we have discussed, and now the investigation for chronic renal disease. This is the investigation, blood investigation, urine investigation, and imaging. Blood investigation, full blood count with PBF, hemoglobin may be reduced, and PBF, normocytic normochromic anemia, and their urea renal function test, urea electrolytes will be imbalanced, and serum electrolytes, potassium may be increased, and sodium may be low. And for renal osteodystrophy, serum calcium normal or low, phosphate will increase, vitamin D level will increase, parathyroid level may be increased. And there is and urine investigation. Urine specific gravity will be low, fixed specific gravity, and proteinuria may be present, and protein creatinine ratio. And we can do the anti-double strand DNA as complement level. And imaging is ultrasonography to know the size of kidney, and X-ray to exclude the renal osteodystrophy, and the DTP deems a renal biopsy. And management of CKD is short-term acute management in avoidance of all nephrotoxic drug and avoidance of dehydration, acid-based management, management for the dietary management, and for proteinuria, AC inhibitor, for hypertension, antihypertensive AC inhibitor, and growth hormone therapy if required. And long-term management, we will involve the pediatrician, nephrologist, endocrinologist, dietitian, clinical psychologist, social worker. And we will do the prevention of the metabolic bone disease by reduction of phosphate intake and vitamin D supplementation, and monitoring of the growth and nutrition, regular dietitian monitoring, and growth hormone and correction of the anemia, erythropoietin given, immunization, and social psychological support lies with school. And another clinical scenario is that during per abdomen examination, we get the kidneys palpable. So the causes of bilateral kidney renal mass is autosomal dominant polycystic kidney disease, autosomal recessive polycystic kidney disease, bilateral hydronephrosis, bilateral dysplastic kidney, renal cell carcinoma. And unilateral is hydronephrosis secondary to PUG obstruction, unilateral dysplastic kidney, Wilms tumor, neuroblastoma, renal vein thrombosis, and fecal mass. So how can we distinguish it is fecal mass or kidney? The thing is that fecal mass is not indentable. Yes, and the complication of autosomal dominant polycystic kidney disease, there may be abdominal pain due to rupture, hematuria, proteinuria, recurrent UTI, hypertension, CKD, pancreatic cyst, it is the association, and intracranial aneurysm. And treatment is supportive treatment is AC inhibitor, and if there is advanced kidney disease, so renal transplantation. And what is the difference? How can we differentiate between Wilms tumor and neuroblastoma? Age of presentation: neuroblastoma less than 2 years, Wilms tumor more than 2 years. And usually neuroblastoma is unilateral, Wilms tumor usually unilateral, but 5 to 10% it may be bilateral. In both cases, hypertension is present, but common association of Wilms tumor, there may be raccoon eye, oxoclonus, myoclonus jerk, and in case of Wilms tumor, associate with Wager and Beckwith-Whitman syndrome. And metastasis of neuroblastoma in the bone, mainly in the bone, and Wilms tumor in the lungs. And vessel engorgement, it encases neuroblastoma, but doesn't invade the vessel, but Wilms tumor it invade the renal vein. And thank you so much. Assalamu alaikum. If you like the video, so please inform me. It will help me to give me mental support, and it's a kind of sadqa jariya if Allah uh, give me this chance. Thank you. Assalamu alaikum.